Good day. I'd like to explain the difference between functional medicine and the standard of care. We actually think that they're very complementary, that the standard of care should focus what they do really, really well, and that's working on acute care. Whereas functional medicine or root cause medicine really focuses on the smoldering, sometimes undetectable chronic conditions and chronic diseases. So there's a great symbiosis between the two. And what we call our program in functional medicine is the hierarchy of health. What we're doing is, number one, we understand the connectivity between all body systems, but there's also a logical progression to follow to ameliorate chronic problems. So in the next several slides, I'm going to show where we are in terms of chronic diseases and why there's a need for the marriage between the standard of care and functional root cause medicine focused on chronic conditions. So from the CDC, we see that 60% of American adults, 6 in 10, have at least one chronic condition, and 4 in 10, or 40%, have at least two chronic conditions. So there's a severe problem here. And the CDC says that 90% of morbidity, mortality, and healthcare costs are related to chronic conditions. So we have to pay more attention to this disease state, the chronic diseases. And we're not getting better at this. We're getting worse. When you look at 2011 to 2016, mortality from cardiovascular disease, a chronic condition, has gone up by 4.3%. And this is despite the fact that we have a very large percent of population on disease mitigating medications like statin drugs for lowering cholesterol and blood pressure medications. So this is obviously not working to the level that we would hope. And what we're seeing is that even in healthy places, chronic disease mortality from cardiovascular disease are up. And in some places around the country, it's up double digit from 2011 to 2016. This is unacceptable. What we see here from the RAND Corporation is based on the last slide, is that the trajectory for chronic conditions in America are significantly up. So we have to admit that the standard of care and the management of chronic conditions is not solving the underlying problem. In this chart, we're showing that this is really very much an American conundrum, where Americans, compared to the 35 other developed nations across the globe, live 2.5 years less, yet we're spending 2.5 times more on healthcare. So obviously, all that money is not necessarily being funneled down the right channel. The black population is particularly hard hit, whereas African American as a single ethnicity has the worst health on average in America. And basically the statistics show that in every category of chronic disease, the African American population is 50% more susceptible and has 50% more chronic conditions across the board, regardless of age. Sadly, too, the same statistic holds true for early mortality, whereas African Americans basically die at 50% higher rates, regardless of age and regardless of cause. But mainly the causes are smoldering chronic conditions. So there's clearly a need for the marriage between acute care and the standard of care and chronic care and chronic disease reversal and prevention that functional medicine brings to the table. Now, this is not just a situation of the socioeconomically challenged individuals, as we can see from this slide, that many prominent, well-to-do African Americans have died suddenly from a chronic condition. So, for example, even Bernard Tyson, the CEO and chairman of Kaiser Permanente, with access to the best that the standard of care has to offer, died suddenly of a heart attack at the age of 60. So we need to do better, and we need to marry these two disciplines. What we ask in functional medicine is, what's in your glass, or how full is your vessel? So in this concept, you're neither perfectly healthy or sick. You lie on a continuum, and it's easy to determine why someone like Tyson might have been at risk for dying young if we accurately and carefully measured how full his glass was for risk, for physiological changes that are adverse, that may not manifest as a condition right away, but is smoldering in the background and causing significant risk for the future. Let's look at COVID-19 and how it relates to chronic conditions. Now we see America has the most chronic conditions really in the developed nations based on early mortality and costs. So our population, arguably, is the most at risk for dying from COVID-19 or having severe conditions. So if we look at the difference between someone with cardiovascular disease and someone perfectly healthy, the mortality rate from COVID-19 escalates by 95%. Or in this case, they say, it's 1,200% relativistically, but on an absolute scale, it's a 95% increase. Yet the flu vaccine, or a vaccine that we're hoping for COVID-19, using the flu vaccine as a surrogate in 2019-2020, was only 45% effective. From saving lives for having the flu, we're not really sure, but it's not highly effective. And mask mandates in COVID-19 are only 2% effective. And this is a well-documented study. So really, what we want to do is ameliorate the chronic conditions. This is where at least 95% of our focus should be as practitioners. And it's really a functional medicine job to reverse these conditions, because the data shows that when you're managing chronic conditions, per this chart here, that the mortality from COVID-19 is still extraordinarily high because we're not solving the underlying risks associated with the chronic condition. So what functional medicine is really doing is not just addressing the what, high blood pressure, obesity, peripheral artery disease, but we're addressing the why. Now, the why is not a statin deficiency in hyperlipidemia, for example. There's something underlying that we have to get to, and that's what functional medicine is particularly good at. Let's look at the African American population, and here's a couple studies that show that really an underlying problem is nutrient deficiency. So hypertension is related to nutrient deficiency in African Americans. There's racial disparities in preterm birth that has a potential role in nutrient deficiency. So it's not the statin, it's not the blood pressure medication. It's counseling and working with individuals to improve their nutrient status. That's the why. So we also need to recognize, so that's risk, but we also need to understand the cues in physiology. And this paper here from Harvard Medical School, number one, says there's not enough data in African Americans, and I believe the Black Health Trust can really contribute to that conundrum. But also, certain markers that are elevated in the general population actually infer more risk in the African American population, something as simple as white blood cell counts, or fibrinogen status, or inflammatory markers. So we need to be aware that when we see these markers, we can't always just use the standard of care reference ranges or reference intervals to make a decision about risk. We have to look under the covers to see what these values really mean in the context of health in the African American community. And we've worked very hard to establish these, what I would consider, new normals based on the most important outcome that we would all consider, and that is the risk for early mortality. And when you look at something like white blood cell counts or fibrinogen from the context of an early mortality risk tied to that marker, the range of normal is much, much tighter and helps us predict risk for individuals with these elevations much more accurately. So let's just do a little quick rundown of the difference between the standard of care, traditional medicine, and functional medicine. So when we look at things like oral issues, what's primary care doing? not really sure, maybe a referral. But functional medicine is doing a whole host of testing, treating biofilms, testing for pathogens, removing fillings, counseling on root canals, trying to solve the root canal conundrum, recommending removal of root canals and visitation to a biological or functional dentist. Heartburn. It's not an excess acid in the stomach. It's excess acid in the esophagus, mainly caused by insufficient acid in the stomach. So functional medicine understands that. We do an extensive GI map, for example. We're looking at tight junctions. We're looking at the microbiome in great detail. Constipation, leaky gut, thyroid. It's not always a T4 deficiency. Thyroid resistance, if you will, there may be a bottleneck in the liver, where there are not enough nutrients to help the liver convert T4 to T3, or it may be toxicity that's making the liver sluggish, things of that nature. Skin issues. It's not a topical issue in so many cases. It's from within. And what we see in autoimmune conditions, psoriasis, and even rheumatoid arthritis, is what's called leaky gut syndrome. The tight junctions in the stomach are allowing large molecules to pass into the bloodstream that the body reacts to with an immune reaction. And there can be molecular mimicry causing thyroid issues, Hashimoto's or hypothyroidism, or skin issues where certain organs are attacked by our own immune system in response to the attack from things that have passed through a leaky gut. And neurodegeneration, we'll talk about that in more detail in a minute. It's not an acetylcholinesterase inhibitor deficiency. There's something underlying the pathophysiology of the loss of plasticity in the brain. So here's a UCLA and Harvard approach that's very functional. It's not just neurology, where we look at inflammatory status, glycotoxicity, type 3 diabetes, atrophic, where we have shrinkage of the brain due to a number of different factors, toxicity, heavy metals, infection can fall into that. Vascular, we're looking at calcification and hypoxia in the microvascular capillary networks of the brain and throughout the whole body, by the way. Traumatic, that can cause inflammation in the brain, which is very difficult to quiet down. And so you have this perpetual state of inflammation from the traumatic event. So we need to focus on that. And it's not about acetylcholinesterase inhibitors again. And then Dr. Tremp, our mentor at Harvard, showed the profound connection between chronic stealth infections like Lyme, like Toxoplasma gondii, like Chlamydophila pneumoniae, that can contribute to neuroinflammation and downregulation of stem cell activity in the brain, so we're not repairing and recovering damaged tissue. This is a real functional approach. Let's look at inflammatory, or rather functional tests that are very robust. So first, inflammatory labs, not just looking at A1C and chemistry and lipid status, but looking at C-reactive protein, fibrinogen, LDH, repair molecules, SED rate, things like that. But more importantly, interpreting those values from a chronic and smoldering perspective. Oral test done in office at a functional doctor is an oral DNA test. Cone beam, looking for cavitations that are pockets that can hold bacteria. The gut, extensive GI map. Autoimmunity, looking at leaky gut, looking at zonulin, looking at food sensitivities. And we can go into great detail, not just looking at, say, gluten sensitivity, but looking at gliadin and many different polymorphisms that can indicate an allergic reaction. Vascular, we're looking at inflammation and subacute infections. Adrenal dysfunction, hormone balances, toxic metals, the removal of such. We just had a patient that had severe inflammation and sensitivities. It's tied back to mercury and lead toxicity. These are tests that we do. And mycotoxins, a largely ignored field where mold has a profound effect on the immunity and creating vulnerability and toxicity directly, not just indirectly. So we need to look at the African American population is the major risk factors. And they all relate back to the kind of testing that we just referred to. So heart disease, stroke, diabetes at the top of the list, obesity, HIV, AIDS, kidney disease, tobacco usage, cancer, peripheral artery disease, sickle cell disease, high blood pressure, ubiquitous in the black population, and vitamin D deficiency. Again, more the Y, ubiquitous in the black population, and has a profound effect on every one of these conditions. We look at things, not are you either healthy or sick, and this dotted red line shows you the demarcation between someone who would be classified as healthy versus someone who would be classified as sick in the standard of care. But we recognize everybody lies on continuums of health. So we have a risk continuum, a physiological continuum, a pathology or tissue change continuum, and then a disease continuum. And the overlap is clear, and the Y titrates back to a person's risks. Now, physiological change tied to that risk may be need to be ameliorated with more than just dietary or nutrient or lifestyle changes. There may need to be interventions, no question about that. But at least we understand and can place people on these continuums and help them understand their true health status and not just give them the rubber stamp, you're fine for now, your A1C is 6.4. In the meantime, your SED rate's high, your C-reactive protein's high, your white blood cell count is not heading towards sepsis, but it's high. These are the kinds of things we look at, and so we place people accurately on all four of these continuums to help really characterize and create a better workup for our patients, particularly looking at the smoldering. So we have put this into practice, and here's a chart from a paper we're in the process of publishing. We published one on a group of 70. Now we're publishing on a group of 240. And what we show is Continuum 1 risks. We give a risk score, a letter grade, for what we call your risk portfolio. And when we simply move you down that risk portfolio by eliminating simple, small, easily manageable, and embraceable risks, that your physiological status, where you lie on the physiological continuum, which we also give a single score to, what we call your chronic disease temperature, which is an amalgamation of 20 biomarkers, all titrated to an endpoint of early mortality, so we create a risk score from that. We can see that just by moving down the risk continuum for life risks, we move you down the physiological risk continuum. So the subjective life risks, when titrated or improved, lowers your objective risks measured through physiology. So this is a process that we have in practice, and we're publishing evidence-based papers on these topics. Here's some of our publications. So the first one's our patent that explains how we derived the chronic disease temperature single blood biomarker score based on looking at the details of when a biomarker shows an increase in early mortality in peer-reviewed papers. And usually multiple papers are used to determine our normal versus abnormal value. And it's interesting that in the abnormal range, essentially every marker follows what's called a log linear relationship. The next is our paper where we published on 70 individuals and showed not only as we lowered life risks, we lowered physiological risk, but we also improved many pre-existing chronic conditions and diseases. And the third paper we're showing here is that we're arguing that since pre-existing chronic conditions dictate COVID-19 severity of outcomes, and if you have one or multiple chronic conditions, you're the one likely to die from COVID-19. But underlying these chronic conditions is a physiological state of dysbiosis. elevated white blood cells again, elevated uric acid, elevated C-reactive protein, elevated homocysteine. So it's really how full is your glass, how full is your vessel? It's these underlying markers tied to the chronic conditions that we really need to be worrying about, measuring and using that to characterize our patients. So here are some profound results that we've obtained, and here's a case of almost complete reversal of very severe rheumatoid arthritis in 5 months. Nothing done with this gentleman except measuring his blood, measuring his life risk portfolio, and improving his life risk and portfolio, seeing his blood improve, and seeing his physical condition, his physical chronic condition improve. And these are pictures that the patient themselves took and sent to us on his journey out of type 2 diabetes, obesity, and severe rheumatoid arthritis. A psoriasis patient, 3-year journey seeing multiple dermatologists, getting all kinds of topical treatment and light irradiation, red light irradiation, none of which worked. It was actually getting worse. And again, just a lifestyle change. The only difference between this person and the rheumatoid arthritis person is we actually took this person who was on a statin drug off that drug and did not see hyperlipidemia as a result of that, but that was, we believe, a contributing factor to the improvement in this individual's health status. So that's all we want to discuss today. What we really need to understand is we're losing the battle in chronic disease and chronic conditions. Functional root cause medicine has robust methodologies to improve outcomes, not just symptoms, but true underlying disease causation. And we need to marry the traditional acute care to the functional chronic care. And all the information you see here is evidence-based from Emory, from Howard, from Harvard Medical School, and from MIT. The team that we assembled put together very simple but profound algorithms to measure where all our people are on the hierarchy of health, if you will, the health continuums, and then providing actionable interventions that can be done to improve the status of the health of these individuals from a chronic perspective. Dr. Tom Lewis and Dr. Michael Carter, I appreciate your time. Thank you very much.